So, incidental finding on this case. Do you guys see my screen?
Yeah.
Yes.
Yeah.
There's the linear thing, anterior to the diaphragm cura.
Yeah.
Or there's it's like a vessel or something. And then it goes from. I love my coronals. Can you show me the coronals?
Sure.
And maybe zoom in if that's like get rid of the chest if it's not relevant.
I don't think the coronal is going to help here.
Helps.
I can show Saj as well.
Just tell us what it is. There's like some line in front of the diaphragm.
Yeah, no, coronal is not as.
Yeah, coronal's not helpful. Sagittal, yeah, good. What is that thing in front of the,
Partial duplication of the diaphragm.
there's also a lot of inflammatory stuff anteriorly, like abdominal wall, but I'm getting distracted.
Yeah, those are like
More
patients
about duplication of the diaphragm.
cholecystectomy and stuff.
Oh,
Wait, Yashant, tell us more about duplication of the diaphragm. I've never thought about that or heard of it.
It's more commonly seen on the right side. It may be associated with cardiovascular anomalies. Also, it may be associated with maldevelopment of the ipsilateral lung. I'm just pulling up literature for you guys. One of the This is from one of the articles from Radiographics. Partial duplication, it's more commonly on the right side, may be associated with cardiovascular anomalies. Our patient did not have one, and may also be associated with maldevelopment of the ipsilateral lung.
Wow. I've never seen that or heard of it, but now that we have, maybe we'll start seeing it.
Mm-hmm.
I think I would have just blown right by it. Cool. Thank you.
Sure. Much disease.
What disease?
Much. Can you go down? Like, can you scroll through? Yeah. No, much is actually left-sided. Okay.
I don't know.
I have two differentials.
it looks like perinephric lymphangiomas, or there's like cystic stuff around the right kidney.
I have one more differential, glomerulocystic, but that should be bilateral.
Yes. So actually, that's what this is. This is glomerulocystic disease, and I'm going to pull over a cookie bites. Can you guys see my cookie bites?
Yes.
Okay. So it's a rare cystic kidney disease, and it's characterized by these cortical cysts here. They're actually cystic dilation of Bowman's capsule. It's autosomal dominant. It can be sporadic, but it's usually autosomal dominant, and it's usually bilateral. But however, it can be unilateral, and when it is unilateral, it's usually not. It's usually the sporadic type. So yeah, it's just like if you Google it, like it's just classically like this, like all these like subcapsular cysts here.
That's cool.
Yeah.
It's a patient who came in with acute pain. Well, actually, the pain was not acute, but she came in for the pain.
Is that ovary?
Yeah, some kind of cystic
Oh,
process.
let me tell you, the patient has a history of endometriosis and had a left urethrectomy and hysterectomy.
Is that like, it seems like there's a cystic process in the pelvis, like maybe there's a endometrioma, like I'd want to get an MRI on this or an ultrasound, and then fluid around it, like maybe it has caused the right ovary to torse and flip to the midline.
So let me give you the MR, but this was a handful of months prior, pre-op to endometriosis surgery. And this is what the pelvis looked like. Patient had a polyp or a fibroid, maybe a polyp. And patient got an ultrasound. after the CT.
Is there any flow in that? I mean, you said that the MRI was just a few months prior, right? So it's probably not a malignancy that developed in the.
Correct. So
Yeah.
it's new.
Yeah, so maybe an endometrioma. Oh wait, in a torsed ovary.
Good. Yes. So I thought it was a torsion ovary, or I said atypical hemorrhagic cyst, just threw it in the differential. And ultrasound
Yeah, like
was
peripheralized
enlarged.
ultrasound.
Yep, exactly. And this is what the operative images look like.
Whoa. So
Yeah.
it was like, was it already?
Yes. So they said it was the gyne surgery said that right ovary edematous with dusky appearance with obvious evidence of torsion around the IP ligament 1.5 times, approximately 5 centimeter hemorrhagic cyst noted. So the IP ligament is the infundibulopelvic ligament. So it connects the ovary to the lateral pelvic wall, and it contains the ovarian vessels, lymphatics and nerves, and it's crucial for the ovarian blood supply. So the right ovary had twisted around the IP ligament 1.5 times, compromising the flow. So after they kind of untwisted it, they then pexed it.
So they were able to save the ovary.
Yes, hopefully it's still okay.
So when you say there was a 5 centimeter hemorrhagic cyst in there too, that makes sense because it did look like there was like some kind of lesion.
Yes,
And there was also peripheralized follicles. Got it. Okay.
Yes. So I'm going to share my screen again. That's portion. So when I saw this, it was so there's actually a layering. There's a very subtle layering density in there. So I think maybe I don't know if one caused the other. Where maybe the cyst was there, and then it was like a lead point that led to the torsion, then became hemorrhagic. From venous congestion. I don't know, but and all of it was new compared to a handful of months prior when the left ovary looked pretty normal. So it made exactly malignancy less likely given the timing. Oh, and I think there's a CT torsion sign. So it was a kind of a ED study, and I thought that you have the whirl sign on ultrasound. I thought I saw that on CT here, which is what made me kind of suggest an urgent evaluation. Right here on the side, right side.
I agree. Yeah. It's amazing though how much easier you can see stuff on MR. Like we would probably see that every beautifully on MR. Yeah.
And it would be a little bit of an overkill, right? And then time in this case is really important. So
yeah. So I want you to focus on this, whatever this is.
Appendico-vesicostomy, Mitrofanoff procedure.
Good, excellent. Yes. So this is the corner of the bladder here that is connected to this tubular structure that is exiting through the right lower quadrant wall. So it's a beautiful example of a Vesico-appendicostomy or a Mitrofanoff. So basically it's used when you need, when you want to make a continent stoma of your bladder. They take the appendix, they attach it here. And then what makes it continent is that they tunnel it through the abdominal wall so that it doesn't leak. And then you catheterize it in order to get the urine out. So that was what the post-surgical procedure is. And you can notice that there's like fat underneath the bladder here. So this patient had a procedure. I'm going to show you their original scan. Okay, this This is their original scan. So what do you think they had? You guys still there?
Yeah,
Round.
there's a lymph node in the left inguinal region.
there a round
There's
ligament
thickening of
inside?
the. No, it looks like a lymph node.
It's a lymph node.
It looks like some kind of cancer. But anyways, the vagina is like, is it the vagina? It looks really thickened, super thickened.
Okay.
Do you have the
You're telling-
sagittal?
Yeah, but I will tell you, it's not the vagina. It's something else, and it almost looks circular here, right?
Like urethra or the vagina. I guess the patient had a GU surgery, so it's probably the urethra.
Yes, exactly.
So it's like a
Yeah,
urethral
yeah. Actually,
malignancy.
this
Is
was
that
an
like a
carcinoma arising in a urethral diverticulum.
diverticulum? Yeah, it's very horseshoey look.
Yep, with a node there. I can show you the sagittal thing. I do think that helps localize it to the urethra probably, but
Yeah, for the
yeah,
pelvis, I mean, that's
area
my
there.
go-to sagittal.
Yep. Yeah, so this was a urethral cancer with a lymph node, and then they did well actually. So then years later, we were seeing the Mitrofanoff, and actually, if you go back here, you can see that they have that inguinal nodal dissection, and then they're missing their urethra here. Yeah, that's it. Hold on, let me just. So what were you asking, Peter?
On your pre-op scan, right, which showed that what looked like a rounded mass along the urethra. Do you all do MRs for that, or this is at CT and then post-treatment?
I would love an MR. This particular patient did not have one, but that study was from 10 years ago from an outside institution.
Oh, okay. Okay.
They did not do an MR at that time, but definitely would help. In this case, we already kind of have some of the staging because of the lymph node we saw. And I think they must have diagnosed it like even on cyst, urethrooscopy kind of thing. And on the CT. But yeah, for any kind of staging, definitely the urethra, like see invasion of adjacent organs, lymph nodes, etc. Like MR is much better. But yeah, this was just for me a rare case because like we don't see urethral cancers that much, and then also the post-op. So okay, who's next?
Me.
Okay, go.
So there is this liver mass. This is the subtraction. And diffusion.
That's like hypervascular and restricting.
Yes.
Wait, was that ADC shining through? And it looks kind of evil grayish there.
Yes, it is evil gray.
Yeah, I don't like it. And is the liver looks cirrhotic?
It's abnormal. Yeah. Dysmorphic.
Not washing out?
I don't think so. And let me pull it up just to confirm.
No. Although there's so much cirrhosis in the liver that.
Sorry, I missed this
Or-
case.
There's an enhancing lesion in a patient with a background liver disease that has.
Oh, sorry, that's post-treatment. Sorry, go ahead.
So I think at this point it's an LR4. We can't bump it up to an LR5 with the restricted diffusion, and it doesn't have washout or capsule.
There's no washout. Here it is. Here's a pre-treatment. Sorry, what I showed you earlier was a post-treatment. But so this turned out to be cholangiocarcinoma. Was biopsied, and the patient underwent Y90 and was referred to us for a liver transplant. So I was like, oh, I mean, I knew we did transplants for hilar, and I learned that we also do transplants for intrahepatic cholangiocarcinoma under strict criteria.
I was gonna say they're more strict about it.
Yes. Yes. So we discussed hilar cholangio before. So for intrahepatic cholangio, the mass has to be less than 3 centimeters. There has to be no extrahepatic disease. So it's actually very similar. Also for hilar, it has to be 3 centimeters in the largest dimension. And no vascular invasion, no evidence of extrahepatic disease, no attempted prior resection with violation of tumor planes. They must be otherwise a reasonable candidate for liver transplant, no microvascular invasion or poorly differentiated histology. Mixed histology types are acceptable. And the pre-transplant workup, they get an MR, MRCP, CT if they can't get MR, they get labs, EUS with sampling of the nodes, the hilar and the celiac lymph nodes, PET as directed, and then the usual transplant evaluation. So this patient has known biopsy-producing cholangio. So before they get listed, we have to perform some kind of local regional ablation. So RFA of a single intrahepatic cholangio, or you can consider alternative treatments such as SBRT or Y90, which is what this patient had, if they are not amenable to RFA. And then we observe for at least 6 months for recurrence. And then reablation if 1 episode of recurrence, and if the mass remains less than 3 centimeters after the initial treatment. And then after 6 months, if there's no evidence of recurrence at the ablated site or Y90 site, and there's no new lesions, then they can get listed for transplant.
That was a great review. I have a couple of questions. So you
Yes.
guys biopsied this, right? Is that
Yes.
right? And my other question is, if you were reading this, would you have called it LR4 or LRM?
That's a really great question.
Because I feel like in my gut, I was actually thinking cholangio, but I felt like unless, like, it's not rim affy, it was affy without washout. So I feel like I would have had to call it LR4, which it does, maybe it doesn't matter because in some places LR4s are all biopsied and this one had enough concerning features.
Yeah, I think based on the enhancement, you would have to call it an LR4.
Yeah.
Arterial enhancement. And then biopsy, of course. So.
Great case. It is also interesting, it's so close to the IVC that like it would be not a great one for resection, but for transplant, I guess it would be different because maybe they could just take a side bite out of the IVC when they do the side-to-side anastomosis. But normally if it like a lesion is very involving like multiple hepatic veins or the IVC, that makes it unresectable.
Yes, and that vascular invasion involvement is a prerequisite. There has to be absence of vascular invasion.
Mm-hmm. But even if there wasn't vascular invasion, if it's just interfacing with the hepatic, like multiple hepatic veins and IVC, often that makes it unresectable because they can't get the margin, you know?
Clean, yeah.
Okay, so this patient presented with elevated bilirubin jaundice. You can see that their bile ducts are dilated here. And I want you to tell me why.
Pylorus looks very thickened. Even the lesser curve.
Of the stomach.
Yeah.
Yes, exactly. So actually, this is a really nice example of Linitus plastica. You can see the dense, enhancing, thickened stomach extending all the way down here. And there was actually sort of like infiltrating tissue that was obstructing the bile duct. And I'm going to show you the IR equivalent. So this was the, the ER, the PTC. And you can see that there's this kind of smooth, but like malignant tapering of the bile duct right there. This turned out to be a poorly differentiated adenocarcinoma of the stomach. Another type that can do this kind of thing is signet ring cell. But anyway, yeah, I just thought it was a nice example of a Linitus plastica. And in this case, it was actually like creeping over into you can see all the soft tissue in the hilum here, and it was actually obstructing the biliary ducts right there.
Is there a carcinomatosis too? Just sorry, you maybe
that was
mentioned it.
another point I was going to make, is that right here, you can see all this nodularity, right? But my surgeons have told me that when it's directly coming, like direct extension off of the stomach, that we should not call it like peritoneal carcinomatosis unless it was like separate, if that makes sense. Because it can spread into the direct lymphatics adjacent to it, and that's not considered like distant disease. When they do surgery, I mean, in this case, there probably is more nodularity extending outwards. When they do these gastric cancer surgeries, they do what's called a D2 lymphadenectomy, where they resect all of the nodal stations. I think there's like more than 20 of them surrounding the stomach. There's several different areas that are like different levels of N1, N2, N3. But one important thing is that, you know, all of the stuff around the stomach is all local disease. Around the, like some of the vessels, like the SMA, celiac axis is a little bit further. But the thing you really want to be careful about is retroperitoneal nodes. So for example, this node I think is highly suspicious, and it's just below the level of the renal veins, and that would be considered a retroperitoneal node. So this would be a distant metastatic node. In cases where we're not sure, but we've drawn attention to a node like that, they can do a PET. And if it's hot, then that's usually like sort of, you know, this is metastatic disease. I have sometimes even biopsied nodes that are retroperitoneal just to kind of prove that this is metastatic. So I just thought it was an interesting case of Linitus plastica causing biliary obstruction and also this probably metastatic retroperitoneal node.
This is a great case. And many times for less advanced cases, I think it's very hard to call prospectively.
Yeah. Gastric cancer can be really tricky. Pause for 1 second. Okay, so you can see that this different patient has fluid going up their esophagus. It looks like their stomach is very distended. Duodenal bulb is also distended. And then we have this interesting thing going on in the pancreatic head / uncinate process.
Is it like a duodenal diverticulum with like a malignancy in it?
Oh, that's a great thought.
Is the pancreatic duct dilated?
Has calcification there. The pancreatic duct is not dilated. It's up here.
And there's no bildial either.
No, but it could be that it's very low.
Pancreatic
Yes,
ductoid.
there's no bildial, there's no pancreatic ductal dill. And then one thing we saw about this, we're like, hey, is this like a cystic thing? It got a central calc. Like, could this be a serous cystadenoma?
Yeah, we need MR.
But then, yeah, exactly. We need an MR. So we get an MR. There it is.
Oh,
Yeah.
interesting.
It kind of looked like a serous cystadenoma on this.
That's exactly like one of the things we were thinking. So we were like,
but it has an interesting, it's almost like it's.
So I'll say on this, we were like,
is it pancreatic?
It's got a central scar with calcification. Maybe it's a serous cystadenoma. We get the MR. It looks kind of it looks like a serous cystadenoma, but then we were like, you know, here it doesn't really look like a serous cystadenoma. And then why was the stomach so distended on that CT? So basically,
there's obstruction of the. It's like a. There's that tube. There's like a soft tissue thingy.
Right. Exactly. Right here, there's like evil gray infiltrating soft tissue.
Yeah. The malignant, obstruction.
Go back to the CT. I think we could have, like, look at this gastric outlet obstruction. And then there's this like abrupt caliber change right here.
So is it like a primary duodenal that's invading the pancreas, or is it almost like it's extra pancreatic.
Nowadays they talk about malignant potential of serous
like there.
Is it like serous cystadenocardinoma?
Okay, great. All these are good questions. So Nelly, I thought exactly the same thing as you. I was like, I think this is like a duodenal cancer that's invading the pancreas, and then maybe it's causing dilated side branches that are mimicking the serous cystadenoma.
It's like serosal too. It's not like a submucosal mass. It's like it's almost like interesting. Okay, I'm curious to see what this thing is now.
Okay, well, I'll tell you. So anyway, they go and do, I said, you know, recommend EGD with EUS biopsy. And they did the EGD. The duodenal mucosa was all smooth, but severely narrowed. And they biopsied this, and it was a pancreatic adeno. So
Wow.
yeah. So
Gosh, all the
one,
different faces of adeno.
yeah. So one, we don't have the double duck sign because it's a low uncinate adeno. Two, statistically, when you're debating, is it from the duodenum or pancreas? Your money's actually on pancreas because it's more common than duodenal. Ultimately, you need to, go do an EGD and EUS and biopsy. Sometimes they still can't tell on just the FNA because it'll come back like pancreatic duodenal primary. But in this case, since the duodenal mucosa was smooth, they said it was like coming from the uncinate process. And then three, I just thought this was a beautiful mimic of a serous adenoma, but was actually the corona sign of dilated ducts in the setting of an adjacent cancer. And here it is. Like, actually now, if you look at it, like, to me, this all looked like apple core kind of whatever. So I was favoring duodenal. But it was just, like you were saying, serosal coming from the outside, narrowing the lumen and actually rising from the low uncinate process of the pancreas.
Nice.
Oh, and then to answer your question, Yashant, about the serous adenocarcinoma, my pathologists have told me that there is actually no such thing, that there is no malignant potential in serous adenomas and they do not degenerate. I have seen one case where we had like a collision tumor where there was a neuroendocrine like kind of intermingling with a serous adenoma, but supposedly there's no such thing as a malignant serous adenoma.
And serous adenocarcinoma is a separate entity, right?
That doesn't exist. According to my pathologist, I don't know, but they said like, that is not, because that would suggest malignant degeneration of a serous adenoma, and they said that doesn't happen. I'm sure, I guess possibly like anything is possible, but it's not like in the ovary where serous and mucinous tumors are in a spectrum from adenoma to adenocarcinoma. The serous of the pancreas is supposed to be like a benign entity.
Okay. I'm ready. So this is comparing to the first case we saw in which there were multiple subcapsular right-sided renal cysts, and the diagnosis there was glomerulocystic. And I said a differential Much disease, but then I realized Much is more common on the left side. So it's not very clear on ultrasound, but we'll start with ultrasound. So we see a couple of cysts which are subcapsular on the left side. Almost all of these cysts are hemorrhagic and they are only on the left side, better seen on this sagittal and also seen on this MR. So it's a newer entity which is called Much disease, multiple unilateral subcapsular cortical hemorrhagic cystic disease of the kidney, and almost always it's on the left side.
Why?
Wow. Seems like there should be an S in that acronym too, though.
Why is it on the left side, Yashant? Any
No explanation. And yeah, S should have been there, but I don't know the paper. There's only one paper from Mayo Rochester which talks about it. And they, for some reason, just said Much only. Let me see if I can put that paper.
It's cool though. I mean, at least it's kind of memorable, multiple unilateral cortical hemorrhagic cysts.
So in their series also, I think every patient had just on the left side. Let's see what their conclusion is. Yeah, just very descriptive, like no other conclusion.
And does it lead to renal insufficiency? What is the? Oh, yeah, it said all patients except one had normal renal function. Interesting. Cool.
So I saw this case when I was collecting pathologies of urethral abnormalities, and when I saw this case, it was like really impressive because I thought it was such a nice case of fistula between the urinary bladder and umbilicus, but little did I know about that in 2021. And when I thought of collecting it, I thought let's just do even MR, and it wasn't present on MR. It's not playing, but it wasn't present on MR. So then when I went and checked back the history, so it was actually Mitrofanoff, which was beautifully explained by Aarti. And yeah, it's a continent procedure. So that's the beauty of it.
In your case, though, it's coming out of the umbilicus.
Yeah, usually it is at umbilicus, but yeah, it can be peri or para-umbilical as well.
Oh, I didn't know it could be umbilical. Cool.
So we have a late teenager patient coming with some pain in the pelvis. This is T2.
Either a angular ectopic or an ACUM, ACUM.
Perfect. Can you tell what is that?
Can you show the T2 again, please?
Sure.
The cystic adenoma is the other DDX.
Differential. Yeah.
Yeah.
Nelly has shown us some ACUMs. I don't remember exactly what it is, but some kind of like cavitated uterine mass. Like it's not a rudimentary
cavitated uterine mass, yeah.
But it's some kind of like non-communicating rudimentary, like leftover cavity.
Mm-hmm. So yeah, as the name suggests, it does not communicate with the main uterine cavity. It can be hemorrhagic. How do we differentiate it from the cystic adenoma? Because like this is not the most sharpest image or the best image, but you do see some myometrium around it. Cystic adenomas won't have myometrium around it, and cystic adenomas will be like more tiny, like up to 5 mm or maybe even 1 centimeter. Although interestingly, this uterine horn, which does not communicate with the main cavity, can itself have its own adenomyoma. So you see this bright spot here, better seen on this. So this is a cystic adenoma for this ACUM, but this itself is not a cystic adenoma. Another pointer towards ACUM being this is the round ligament of the uterus. So it's usually at or below the round ligament of the uterus. And one thing I'm not sure, maybe I read it somewhere, maybe it's more common on the right side, but I may be wrong on that.
I was thinking about that because the cases that I've seen have been predominantly on the right side too.
So I think I've read it somewhere. Yeah, it's more right side. And I mean, what I use as a hint is T1 bright and this round ligament, attachment to the round ligament.
One of the cases that I presented, they resected it and it came back as a cystic adenoma. And it wasn't a small one.
So
like it wasn't 5 millimeters. Correct, yeah.
Would an angular ectopic look like this? Like if their HCG had been elevated, could it also look like this?
Yes, yes.
Okay.
This is a patient with a left-sided cyst that was seen on CT, and this was 1 year prior to the MR. And the patient got characterized with an MR shortly after that CT, and then a year later got another MR. And this is what that MR looks like a year later. And there are no septa, no nodules.
I feel like we see more and more of these, and they're just watching them. A bunch of them we've just said like presumed lymphangioma. It's not like really lobulated, but it looks very simple.
Agree. It looks very simple, and I'm curious how you, in my mind, I think about a duplication cyst versus a lymphangioma. How do you not say this is not a duplication cyst?
That's a great thought. Duplication cyst will have a thick wall, and particularly when we do ultrasound, we see the gut signature. So, and yes, I agree, it's not lobulated, but because it's retroperitoneal, I would still think more in terms of lymphangioma.
Yes,
I agree.
and those two make a difference. So as you mentioned, so colonic duplication cyst, it turns out they're usually found on the mesenteric side of the bowel, and they have a GI mucosa, and they can have ectopic gastric tissue as well. And they have an outer layer muscle that's shared with the native colon. In contrast, colonic lymphangioma are benign lymphatic system. So at least the lymphangiomas that I've seen have been multilocular or septated. And so I thought this could, and then so the colonic duplication cyst, they're important because they're rare. There's been less than 100 cases reported, so extremely rare, but they have high risk of cancer in colonic duplication cysts. So even if the patient's asymptomatic, surgical resection is often recommended because of that. I think the data is still insufficient to make that kind of big statement, but given even 100 cases, right, and the higher risk of it compared to non-colonic duplication cyst, well, it is what it is. I mean, your recommendations and the rigor of your recommendations is limited by the data that you have to support it. So the colonic duplication cysts can occur anywhere along the colon, but the most common place is ileocecal region, again on the mesenteric side of the bowel. So the key message here is just they have very different management. Lymphangioma is benign and left alone, whereas a colonic duplication cyst, although very rare, can have malignant degeneration.
You have to give us the follow-up. Because I
This
still
patient
think,
is
I totally agree. I think this is a conundrum. I have had a gastric duplication cyst that had adenocarcinoma in it. My case of mine did have an area of the wall that was thickened with a little nodular component. That's what pushed us to them to resect it. But otherwise, I feel like you said, these duplication cysts are much more rare, and we do see a lot of lymphangiomas. So I'm still favoring in your case that it's going to be some benign thing. I do think it's nice also you have now several years of stability, but with no concerning nodular part, but yeah, we'd love a follow-up.
Given just how incredible MR is in accurately characterizing lesions, that 100 cases of colonic duplication cysts that's been case reportable, I bet if they actually got MR, if all 100 cases got MR, I think it can accurately differentiate the ones that harbor malignancy and the ones that don't. Like you said,
Yeah.
that your case had mural nodularity and suspicious feature, and this looks simple. And if it were me, I would just survey this with MR. I would not take it out.
Me too.
Uh, 47, ready?
Yeah.
Aarti? So
Yep.
47-year-old guy who had a strong family history of cardiac disease, and so he had a CTA of the coronaries, and they found 3 or 4 blocks. And at the time when they did that, the radiologist reported, and I don't have the CT from outside, but they reported they saw something in the pancreas. And unfortunately, however it worked out, they ended up getting 3 stents without the pancreas getting evaluated. And so this guy's had stents, and then he's on these 2 blood thinners. And then they decide to do another MRI of the abdomen to evaluate for the pancreas. So basically concentrate on the pancreas. He's completely asymptomatic, okay, for the pancreas or for the abdomen.
Whoa, that looks just like my case, where there's some
I
like,
don't-
soft tissue along the uncinate.
Right. So you're seeing that, right? And then this is the pre-T1. And then this is the arterial phase. And then this is the delayed phase. And so now the question was, it was read as, okay, what do you guys think?
Can you zoom in on that coronal haste?
Sure.
T2, it is evil gray, so like pancreatic still.
Yeah,
I mean, I think it needs a biopsy.
agree. US.
So basically they were told he can't have a biopsy for 6 months because he's on these blood thinners or whatever. So anyway, it's also restricting. Okay. So they went to
Also,
MD
like,
Anderson.
in addition to adeno, think about like neuroendocrine, because just as it has like a lobulated kind of border too.
Right. So they went to MD Anderson for because I mean it's a young guy. He's literally 47. He's a physician. He was he's had these cardiac stents, and I actually showed Khalid this case because I wasn't sure what. And basically same thing. He said that they need to get a biopsy. So he had an EUS before doing an EUS biopsy. They decided to do a PET CT because the other thought was it can be a neuroendocrine tumor because it's not really doing anything to the pancreatic duct. He's completely asymptomatic, and that scan was negative. And I don't have access to that scan either. But basically, he had a biopsy which was negative. He had his CA19-9 is normal. And so my question to you all would, what would you do next? And I'll tell you what they decided to do, but.
Is there any history of pancreatitis, chronic pancreatitis? Like this is a little
There's
bit
no history, no, nothing at all.
Is it one of those weird things like just focal IgG4?
So they didn't get on the path. They did not. Path was basically just bland pancreatic cells.
Did they draw IgG? Blood?
I don't know that. So I don't know that. But anyway, so I'll tell you what they decided. So they had this was discussed in their MDC, and whoever their pancreatic expert there is, they think this is just focal chronic pancreatitis. And basically nothing needs to be done, just 6-month follow-up. And
I
that's
would still get an
scary to me because it literally looked like a pancreatic adenocarcinoma. And
yeah, I mean, I think it could go either way, but when you said like the not doing anything to the ducts, like that was my case. It wasn't doing anything to the ducts, and it was just because it was so low. Like sometimes, it's just
exactly. So I'm
not sure I
wanted
would
to present this to see what do you think people at your institutions would have done with something like this?
We had a case similar to this, and a patient had a pancreatic head mass, had EUS twice, PET CT, MRI multiple times. And then finally we thought about IgG4 after like significant workup, and it was significantly high. Yes. So it's like the great mimicker. It just has to be ruled out.
Okay.
agree.
PET was positive. Like, yeah, it smells like pancreatic cancer. It looks like pancreatic cancer, and it could be IgG4.
Okay.
And the biopsy can be really like difficult because it causes a lot of
Yes.
fibrosis. So often you don't get as much of the IgG4 cells. So we've sometimes had to do like big core biopsies to even get like all the, to meet the criteria, and to also see all the other stuff like storiform fibrosis and the lymphoplasmacytic infiltrates. Yashant, this is also reminding me of the case that I sent you for your radiographics paper, which I had a case just like what Nelly described.
Yeah.
Pancreatic mass, multiple biopsies, MRI, hot on PET CT, more biopsies, and then in the end, it ended up being Rosai Dorfman. So I don't bring that up ever, but it is a possibility. And chronic pancreatitis, I think, is also a possibility. So I love the, like, check the IgG4, maybe do an FDG PET, and I would do probably a short-term follow-up because, sometimes biopsy is negative, but
Right. And I mean, they couldn't do a thicker biopsy because he's, on these blood
yeah.
tests. So,
Yeah.
so I'll give you guys a follow-up because we will get a follow-up on him. But it was just a very interesting, kind of really scary case more than anything else.
Yeah. And you don't want to sit on a pancreatic cancer too. So
Yep.
So there's some Escher devices, fallopian tube closure devices. This is the endometrial cavity, looks a little thickened. The patient was postmenopausal. That's a different situation. And then we see this process here. Any thoughts? What would you recommend there?
Lymphoma?
Okay. Because it looks kind of blobby and bland.
How old is the patient?
60. With sudden left lower quadrant pain.
Is it a localized hematoma? But it is very sharp. It can't be a hematoma. Still
Yeah,
lymphoma.
we thought maybe.
Can I see the sagittal?
Is it a second moiety?
Okay, here's the sag. So there's the uterus, and that's the thing.
Some ovarian lesion?
So that's what we thought. We said
It's very retrouterine. It's
okay. So
yeah,
we
MR. Yes, thank you for the MR.
that's what we do at Emory. Is we do a lot of MR. And this is what it looked like on the T2.
Huh.
Looks
Okay.
tubular.
Kind of, yeah. Looks tubular, intermediate, kind of. This is the pre. Oops. Pre. Delayed. Subtraction.
Low level enhancement. Yeah.
And this is the high res T2.
Oh.
Fallopian tube cancer?
It's something adnexal. There's like the left adnexal, the vessels are dilated, so supplying that. So some left ovarian thing or fallopian tube thing.
Okay, so yeah, when we first looked at this, somebody was like, "Oh, is this like malignancy? Like what Yashant said? Is that a fallopian tube cancer?" I briefly was like, "Is that a cotyledonoid fibroid?" Because it looked a little like little serpiginous little things. But another key here, do you see this little pedicle coming?
Oh, the torus. Oh,
Yeah,
wait, is the
like
uterus
a torus.
torus? Wait. I'm so confused. Wait, that's going to wait. Wait, go down. What is that going to? That there is a swirl.
There is a swirl. Something's torsed.
Well, yeah.
Isolated tubal torsion.
Keep going. Go down all the way. And but that's the uterus. Isn't that the uterus?
Yep. And then
So
something
it's like a
coming
torus uterus. It's all torsed, all of it. It's like it's like it's torsed around some pedicle, and so the uterus, the ovary, everything is like, and then you have engorged vessels.
Yes. Okay, perfect. I will gonna show you one more thing.
Maybe that's that IP ligament, infundibulopubic ligament. It's torsed around that thing.
I'm showing you one more thing.
Oh, endometriosis.
Meek syndrome. It's a
Meek
fibroma.
syndrome?
Yeah, it's Meek syndrome. It's a torsed fibroma.
Finally, I got something right.
Okay, let me show you. So this is like basically the fallopian tube and vessels that are torsed. These are all actually engorged vessels. And this is the devascularized fibroma. And so one one clue, first of all, she had sudden left lower quadrant pain. It's a solid mass with a pedicle to it. We were briefly like, oh, is it a torsed fibroid, exophytic fibroid, right? With like a pedicle. But we kind of favored that it just really looked like maybe more of an adnexal thing, and that these were engorged vessels. And then she had the effusion, so we called it a torsed fibroma, and that's what it was. And then
Wow, that needs to go on the unknown cases on
Well, you know
SAR.
what's crazy is that I actually had a torsed fibroma with Meek syndrome in residency, and I put it in my board review. So now every year at board review, I like have this case in there. And so when I saw this, I was like, this reminds me so much of something. Like, it reminds me of my torsed fibroma case. And then with the effusion, I got like super excited about the Meek syndrome. The part that I got confused by was this stuff, and couldn't like put it together. Like, I was like, is this also a fibroid? What is this thing? But in the end, those were just like engorged vessels. Yeah. Oh, the other cool thing, this stuff I thought was going to be like endometrial hyperplasia, and this was all an endocervical polyp.
Oh, wow.
I'm going to show you. And yeah, polyps can be cystic like this. So that was actually oh yeah, that was the recon, so we didn't have a sag, but yep. Oh yeah, here actually nicely. Do you see the swirl?
Yeah.
Yeah.
Yeah. So fibroma. And actually, like, if you did the, ORADs, this would be an ORADs 2, because it's like pretty T2 dark. And then the torse part, it went along that it wasn't enhancing a lot. So my colleague Ayushi and I called it prospectively, so we were happy to see the path. Okay, let me stop.
Great case. Yeah, great.
I have a case.
Okay.
Yes. Patient with poorly controlled type 2 diabetes came in with septic shock, and they got CT, and this is what the CT showed.
Really bad pylo.
I'm
And maybe no, not XGP.
So yes, it's awful. I mean, this is like the worst pylo I've ever seen. Maybe I haven't seen. I mean, I know I definitely seen all of it, but there's areas where there's just frank non-enhancement, and on pre's, it's dense, right? So right there, and I was thinking, like, could this be like necrotizing pyelonephritis? Which is a patient has poorly controlled, patient has significant risk factors, obviously, and was in septic shock, urosepsis. So anyways, the patient got managed conservatively. They stented it. They actually put a drain in it, and aggressive IV antibiotics, and patient did well, shockingly.
It almost looks like, their whole story sounds almost like emphysematous pylo minus the air. Because you treat it the same way, like you put in big drains and antibiotics and that kind of stuff. Same risk factors.
Do these kidneys recover?
At least with emphysematous pylo, not really. But I do know that it's really hard to go and do a nephrectomy in this case because there's just like you lose all the fat planes. It's like there's so much inflammation that it's better to treat them with drains and antibiotics if you can.
I agree, like it looks bad, but I think I would use the term necrotizing in my report only when I see air, like necrotizing fasciitis or anywhere else also.
But in the pancreas, we don't use the term just with air.
True. That is true, yeah.
So what's probably the best way to describe it then? Because I mean, it doesn't have air, so we don't say emphysematous, or do we? We can, right? Because emphysematous by definition means there's air.
And I don't know why those areas were hyperdense. Like, was it just hemorrhage?
I thought it was hemorrhagic, like
or was it coagulation, necrosis?
That's a good point. I don't know.
Some of these things are just like academic for us. It's interesting. Recently, I was talking to my gastroenterologist or like my colleague who's a gastroenterologist, and I was like, oh, like, do you care if we tell you what percentage is necrotizing versus not? And he's like, no, we don't even care if you tell us it's necrotizing or not. I was like, what? I'm like, what about like interstitial edematous versus necrotizing? And he's like, no, we basically just treat the patient. We don't use Ranson's criteria anymore. We don't use Balthazar criteria. We don't use any of these criteria. We just resuscitate the patient, and then like time tells us like how they do.
Then how do they like see clinically if the patient is worse or better prognosis? They have to
They
have a
follow their
clinical.
clinical parameters. Like, is their blood pressure stabilizing? Is it, pain stabilizing? Are they able to tell, this and that? But he also said, like, in the case that I was showing, I was like, oh, this is like hemorrhagic necrotizing pancreatitis. And they just wanted to know if there was like, any active bleeding. And then beyond that, the patient was in the ICU, and they were going to treat them for like abdominal compartment syndrome, which they got through a bladder pressure. But otherwise, they said like it doesn't change their management at all. They just do aggressive resuscitation. So it doesn't matter what we call it. Because all of the things that we were calling are like all kind of prognosticating things, right? Like if you say there's greater than 50% necrosis, then there's like worse morbidity and mortality, but that doesn't change their management. And some patients like fully recover from necrotizing pancreatitis. So they just like treat the clinical stuff, like the blood pressure and all these things,
I've seen multiple patients recover from serious necrotizing pancreatitis.
Yeah. Yeah.
I mean, they have terrible, like, portal vein like occlusion and all this stuff later on, but they're still doing okay.
Yeah, and that's why it's good to be in like a really specialized center where they can do aggressive like endoscopic debridement, surgical nephrectomy, whatever. But
This gastrostomy,
we do a lot of that, and the patients actually do well. But I just thought it was so funny because like, we debate these terms and they're like, we don't really care. So I think for your case, like, I don't know if they would care if you say it's necrotizing or not, just like extremely severe pyelo with areas of hemorrhagic, non-enhancement. Or you could even say necrotizing, but I don't think really that's going to change if you say that or not.
Yes, you're right, because it comes down to the patient's condition, and patient was acutely ill, and it wasn't even like a operative candidate because they were acutely ill from septic for their sepsis, and then they went into cardiogenic failure, and so it wasn't even an operative candidate either way, with just terribly controlled diabetes. So it's conservative, and eventually the patient will have to. I mean, either way, there's very poor prognosis for the left kidney to remain anything that would be viable or whatever, but they're gonna it's just follow up.
Looks like you have another case.
Yeah.
Okay.
So I will start with this. So yes, you were right. There is only pancreatic serous cyst adenoma, and it is difficult to differentiate between the benign and malignant variants. The only time we call it malignant is if it has shown metastasis. This line. And I can show you the case if we have all seen this.
So before you go ahead, Yashant. So when we read these typical serous cyst adenomas, right? We say no further follow-up is needed.
Sure.
So then when do we, if these people are claiming there is a cyst adenocarcinoma?
I think that would be like, one in like some 10,000, 20,000 cases, something, or even less than that. So this is just a case report. I don't think this is a complete, like, full-fledged review article. It was a case report. So I presume it would be like extremely, extremely rare, because in last so many years, I've only seen one case. So I don't think like, it changes our management or the way we report on a general or a broad basis. What I'm showing and the case that I'm showing is just like more of an academic interest, once in a blue moon kind of a thing.
You have a case?
Yes.
Oh, cool. Sure.
So this patient comes with this pancreatic lesion. And he also has something in the liver. And for some reason, my other studies are not loading. But a couple of years later, the number and the size of liver lesions also increased.
Wait, we sat on the liver lesion?
Sorry, say it again.
Was there any evaluation of the liver lesion?
Yeah, both liver lesion as well as the pancreas were evaluated. So when they took this out and they did biopsy, they said serous cyst adenoma. And when they biopsied this, then they said probably because this is mets from here, so it is serous cyst adenocarcinoma.
But this liver thing came back as adenocarcinoma.
Liver thing came back as...
Like, did it come back as like there was actually serous cyst adenoma in that liver thing, or just adenocarcinoma?
Liver segment 5 core biopsy, metastatic serous cyst adenocarcinoma consistent with spread from pancreas.
Wow.
Because I do think there are collision lesions. So for example, like seeing how massive the serous cyst adenoma is, I wouldn't like, you could imagine that an adenocarcinoma could arise there and that could metastasize. So yeah, I don't know.
But
even that report, and I'm not trying to argue too much.
no, but the histopath says metastatic serous.
Right, but
That is
sometimes the path says like that based on like, oh, based on the fact that there was a serous cyst adenoma in the kidney. I'm sorry, in the pancreas.
Yeah, possible. That is totally possible.
But yeah, I mean, it's good to know. And I guess maybe the fact that it was so massive, I don't know. Back to Kadar's question, like when would we then like,
Maybe
obviously
when
with that
it
liver
looks
lesion.
ugly. I agree. It definitely looks ugly.
But I've seen ugly, massive serous adenomas like this that are just benign serous adenomas, And
Do
especially
we have MR? I mean, and I don't know that it'll make a difference,
No,
but
sorry, no MR.
yeah,
I
in
mean-
CT they can often look solid and kind of ugly, but it's because they have so much vascular septae.
like I wonder if there's areas that are solid and restricting diffusion and just look bad.
No, I'm just saying, I think all the MRs which were done were after pancreatectomy. Sorry about that.
No, like Aarti said, it's just academic. I mean, it needs to come out. Just
Yeah, but good reminder. I will go back and tell my pathologist. Okay, great to see you guys. Bye.
thanks all. Bye.
Thank you. Bye.
Bye. Nelly, can you add me on the thing, please?